Good morning, everyone. I'm Dr. Cao Yang from the first affiliate hospital of Harbin Medical University. Thanks for the introduction of Professor Qian. And today I'm honored to share the topic of how should we treat calcified nodule. There is no conflict of interest. We all know that calcified nodule is a very unique and special type of the calcification. At the very beginning, we found that the calcified nodule is a trigger of ACS events. During the biopsy of the cardiac death patient, we found that the calcific nodule is an accumulation of smaller nodular calcification on the surface of the plaque, and also with some thrombus attached to the surface of the plaque. And also we can see that it's one of the cause for the ACS events, accompanied of about 3% to 7% of all the ACS events. The very first case in human identification of calcific nodule is on this paper, 1996, by Dr. Gary Mintz. We found that there is a filling defect at the proximal part of the LAD. However, from the angiography, it is hard to tell whether this one is a thrombus or the plaque rupture or anything else. But by the intravascular imaging like IVUS, we can identify that this is a very unique kind of the calcification that protrude into the vessel lumen. It's called the calcified nodule. And also by the year 2000, the AHA listed a new classification of the atherosclerosis, which here, the calcified nodule is listed here, which is a trigger of thrombus event. And nowadays that in the clinical practice, it is relatively difficult to identify how can we diagnose a calcific nodule by the angiography only, because just we see that it is hard to distinguish it from thrombus and plaque rupture. So intravascular imaging, either IVUS or OCT, is the golden standard to diagnose the calcific nodule in human being. And here is the case report from our site. The RCA is severely stenosis at the ostium of the RCA with a 73 years female with unstable angina pectoris. And from the IVUS pullback, we can see at the ostium of the RCA, there is a very severe and eccentric calcified lesion that protrude into the vascular lumen with some calcified material on the surface of the plaque. So basically, from the IVUS image, it is relatively difficult to make a subtype classification. We cannot tell this one is eruptive calcific nodule or a non-eruptive calcific nodule. So next one is the prevalence of the calcific nodule. Many papers have tried to calculate the prevalence or incidence of the calcific nodule in the coronary artery tree. This is a relatively very early publication by Professor Xu Yingjia at the CRF, published on Circulation on 2012. We can see that she indicated the calcific nodule is mainly on the proximal part of the coronary artery, LAD, circ, etc. And this one agrees with the other publications. We can see on this paper, Dr. Li indicated that its majority located at the proximal part of the RCA and LAD, which is mainly on the bifurcation part of the left main trunk and the proximal part of the RCA. The rate is about 4%. And also in different kind of cohort, the prevalence of the calcific nodule differs a lot. For example, majority of the time, it is associated with ACS events. So in the ACS cohort, we can see it's around 3 to 5% in the ACS cohort by the OCT or IVUS. And the very interesting part is that we all know calcific nodule is associated with relatively higher MACE thrombus event. And also when we diagnose, we can see after stenting, the instant calcific nodule regrowth or reprotrusion through the stents into the lumen with around 4.9% after the stenting. So it's relatively similar to the prevalence of de novo calcific nodule. So there is a potential hypothesis maybe the calcific nodule after stenting is almost 100% going to cause an instant restenosis with the typical mechanism of regrowth or reprotrusion into the stent struts. And also the other studies, we can see that by Dr. I think Seto, he evaluated the different prognosis and also the natural history of the eruptive calcific nodule and the non-eruptive calcific nodule. We can see that the de novo prevalence is around 7% for the ACS cohort. The third part is pathogenesis. So what's the mechanism that formed the calcified nodule? Currently, we still do not have an answer for this one. We also know that the calcification formation into the vessel wall has many mechanisms, including the abnormal calcium or salt deposition, this kind of immune system stimulation, a molecular mechanism, etc. is similar to that, to the formation of the bone or the teeth. But one of the hypotheses or mechanism to explain the formation of the calcified nodule is a hinge motion effect, which means that, for example, at a certain part of the coronary artery, especially the mid part of the RCA, at the systole phase and the diastole phase of the heart movement, we can see this part of coronary artery is the movement is relatively very big. So there is a delta angle between the systole phase and the diastole phase. So this kind of difference between these two angles can indicate whether this kind of hinge motion is very severe or not. And also this kind of hinge motion effect can cause the calcium plate to fracture into small pieces as a hinge motion part. So that is relatively very small, nodular, very sharp, very irregular piece of calcium plate that is shattered by the movement of the hinge motion, maybe will damage the surrounding tissue or maybe cause an intraplaque hemorrhage or inflammation formation. So which causes the relatively rapid progression of the plaque and then initially forms the calcified nodule. However, this kind of phenomenon or mechanism can only explain the formation of non-eruptive calcified nodule. But currently, we still do not have an answer of the mechanism to formation of the eruptive calcified nodule. And we just mentioned that the calcified nodule can be classified into two groups by the relatively social or formal papers listed here. So one on the left is called the eruptive ones, which means that it's relatively unstable. With some thrombus on the surface, very high attenuation. Sometimes maybe some macrophage is on the surface attached to the surface of the part, which means that this part is closely related to ACS events or thrombus events. On the right hand, we can see it's a non-eruptive calcified nodule, which means it's relatively intact. Not ruptured, smooth surface on the top of the calcified nodule, and also maybe there is some attenuation with very thick calcium at behind. So these are the relatively two different types of calcified nodule currently. However, we notice that there is a relatively third form or type of the calcium protrusion. It's so different from the calcified nodule we just mentioned. One thing is that there is not so severe attenuation at the back. The other things is similar. It's concentric protruded and also may relatively cause very severe stent under expansion, and also the insymmetry index is relatively high. So we doubt whether this one could be also classified as one part of the calcified nodule or not, but currently no one combines them together. And so there is some difference combined compared to the eruptive one, non-eruptive one, or calcium protrusion. So we can see this is the difference. And also when we look closely to the severely calcified lesion, we can see that the calcium protrusion relatively, we can see the angiography angle from the angiography or the OCT calcium arc by the intravascular imaging is similar to that of the eruptive ones. However, from angiography is relatively merely detected by the angiography. So we can see that maybe during clinical practice, we can also try to involve the protruding calcium to try to make the similar strategies during the plaque modification and PCS strategies. So next one is a natural history of untreated calcium nodules. Now that we know what it is, it's a trigger of the ACS events. Second one is that we know what it is like by the intravascular imaging, by IVUS OCT, we know what it is. So what happens if we do not treat it? What about we just leave it, make some full medication to treat it? So here is a natural history that published by Dr. Prati by European intervention in the year 2020. We can see that if we leave it, the relatively eruptive calcific nodule is associated with around about maybe over 2 times of the MACE events compared to that of no calcific nodule or non-eruptive calcific nodule, which means that the eruptive ones, which labeled here with the red line, is associated with worse clinical, prognosis, which means that almost twice the MACE events, the thrombotic events or the myocardial infarction. So we know that eruptive ones, if you do not treat it, it's going to cause an ACS events very high likely. And also, if you look at here, we can see that during the follow-up, you can see that the calcific nodule group is another study. The calcific nodule group is associated with relatively very high MACE events. If you stand it after stenting, still the instant restenosis rate in the calcific nodule group is very high compared to that of the non-calcific nodule group. So it's really going to cause an ACS event, and also after stenting is associated with relatively very high ISR rate. So how should we treat this kind of a calcific nodule? We know what it is. We can make subgroup classification, and we know the natural history of it is poor, and also we know after stenting the ISR rate is relatively high. So what's the plan currently? How should we treat it when we meet an calcific nodule in the daily clinical practice? Okay, here is an example that explains the different instant result of different subtypes of calcific nodule. So on the left, we can see the eruptive calcific nodule. We can see that with typical attenuation after and also after stenting, the stent expansion from this view is relatively fine, because we can see the stent is relatively perfect circle. It's not underexpanded. And although the attenuation on the surface is so high, there is almost not so severe protrusion into the vessel lumen. And on the right, this is the typical non-eruptive calcific nodule. We just mentioned that there is attenuation and the same, but on the surface, it's very clean. There is no shattered, calcium fracture. There is no, thrombus attached on the surface of the plaque. However, we can see after stenting, although we try our best to make the plaque modification or some strategies to shatter the calcium, but we can see the stent expansion is relatively poor compared to the left eruptive calcific nodule. And also we can see the insymmetry index is relatively high on the right. So what's the prognosis of this kind of two different subtypes of calcific nodule? So here we can see it's another chart that Dr. Seto published on 2023, which indicated that the eruptive calcific nodule, this kind of absolute change in the calcium volume is relatively large, which means that eruptive ones are majority more easily to be modified or easily to be pushed, relatively associated with good stent expansion. However, the non-eruptive ones, the volume change of the calcium is relatively small, which means it's relatively dense and hard to shatter or make full stent expansion. So here is another comparison of the stent expansion between different subtypes of the calcific nodule. We can see eruptive ones versus to that of the non-eruptive ones. We can see it's a statistical positive, which means that the stent expansion of the two types is different. And also the other values, we can see the negative remodeling or other two used is dramatically different between these two kind of subtypes. And we just mentioned that the eruptive ones, the natural history is poor. It's associated with almost twice times of the MACE events. However, we can see that after stenting, the eruptive ones is associated with relatively good stent expansion. We just mentioned the stent expansion rate on the eruptive ones is good. However, the target lesion revascularization or target lesion failure in the eruptive ones were higher. So it's very interesting and conflict of these two different subtypes. The eruptive ones is associated with good expansion, but the target lesion failure rate is high, which means that in the eruptive ones, we cannot explain using the current standard of the stent modification or optimization strategies, which means that better stent expansion is almost 100% guarantee to the good prognosis. But in the eruptive ones, no, it is not. So let's check another study that also explains the clinical outcomes of the, calcium nodule after stenting. So we can see this sub-analysis, including the 300 calcium nodules that divided into two groups. One is associated with the calcium nodule, the other is not. And after stenting, we can see during the follow-ups, we can see that the patients with associated with the calcium nodule is associated with relatively, higher percent of the MACE event, which means that the poor prognosis after stenting. And also, if we look more closely into this kind of instant restenosis, we can see the calcium nodule group is the majority of the time, the MACE event is caused by the instant restenosis, which is instant calcium nodule regrowth into the lumen. And during the 2-year follow-up, we can see that is a clinical, statistical significant between the two groups, the eruptive ones and the non-eruptive ones. And the final ones, how should we treat it? We know all the things that we just mentioned about. Eruptive ones is worse, and after PCI is we associated with relatively very high instant restenosis. So currently we have so many tools. We have ROTA, we have orbital, we have shock wave, we have blah, 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 everything. But how should we apply to it? So this is a demonstration of the rotablation in eccentric calcification. So this one demonstrated that when the wear bias is favorable, which means that the wear is close to the target that you want to rota, we can see that this kind of ablation is dramatically very effective. They can erase a great amount of the calcium that is near the wear. So after, further cutting a special balloon dilation and stenting, this one could be perfect. So the main issue is that this kind of wear bias should be favorable. And thanks for the courtesy of Dr. Kashima, we can see use this chart that currently we have so many tricks to adjust the wear bias, which means that if you find the wear is distal from the calcium target, you can try to use, maybe change another gating catheter, change the rota wear, or maybe use here, respiration, where it is, respiration, where it is. Respiration, bias, which means that you tell the patient to take a deep breath and maybe change the angle or some position of the wear position to try to increase the, result of the rotablation. However, sadly, although this is a small number study, we can see that in the calcified nodule groups, we try to use the rota and compare to that without the rota. The instant result and during the follow-up of 1 year, there is no difference between the rota group and the no rota group in the calcium nodule lesions. So which means that maybe the regular rota doesn't work so much in the calcium nodule patients. And here is a SAC expert consensus that published recently indicated that when you meet a calcium nodule, you can try to relatively increase a little bit about the blood-to artery ratio to 0.6 to 0.7, and then try to use other special balloons to modify. And then a sub-analysis of rota shock trial, which compares the rota ablation and the shock wave on the management of the calcium nodule. And still, during the follow-up, we didn't see any clear differences between the two groups in reducing the volume of the plaque and also the stent expansion. And also there are some other studies to compare the IVL and orbital atherectomy. And once again, we didn't see any clear differences. We know the IVL, the shock wave, is widely applied nowadays in the clinical practice. It's relatively easy, not so complex to use. You can just develop the balloon and make some pulse rounds to shatter the sick calcium and maybe in the deep tissue. However, we can see that recent years, many papers were published to indicate the safety and the effectiveness of IVL usage in the calcium nodule. Here is a demonstration. We can see that when we detect the calcium nodule, we use the IVL and then put the stenting. We can see after the IVL, the minimum lumen area increases 5 millimeters square. And after stenting, the minimum stent area increased 7.9 millimeters square after using the shock wave balloon, which means that this is relatively safe and effective. And recently, Professor Ali published a paper, also another research to prove the safety and effectiveness of shockwave balloon for the calcium nodule. And we can see between the two groups, there is no significantly the missed event during the two groups, there is no, different signal between it. So in our world, in our hospital, Professor Li Yue developed a new, AI-associated tool to help us to better understanding the calcium location and distribution in the coronary artery. Use CT reconstruction, we can clearly see the calcium location and distribution as well as formation. And also we can make some specific tools. First, we use U-ROTA to modify the plaque, and then we use this kind of OCT. I was merge the catheter to one pull back to make two image. And then we use the shockwave balloon to further modify the plaque. This one in the current study is called the rotatripsy, which means that you combine the rota and the AVL balloons to modify the plaque. And also there are other combinations to try to combine at least the two modalities to try to modify the calcium nodule. We can use ELECA or shockwave balloon. We can use ROTA and ELECA, depends on what tools and what toys you have in your cath lab. And currently, there is no clear answer how should we treat the calcium nodule currently. At least there is no, hard or very strong evidence studies to declare that a certain flow chart or a tool combination could change the prognosis of the patient. But currently, we can see many flow charts were indicated first, to use a balloon. You can detect whether this one is deformable or not. Maybe an NC balloon or other types of balloon with from two different kind of angles to check whether the balloon can open well or not. And then decide you directly stenting or use the rota or combination, rota lithotripsy, etc. However, the question is still, if you guarantee a good stent expansion, you still cannot stop the instant restenosis in the eruptive calcium nodule. So nowadays we are trying also put our focus on the medication to treat the calcium nodule patients, maybe stop the inflammation or stop the higher progression dose of the calcium. So here is a small summary. What we know eruptive ones is worse, and no matter the natural history or the after the stenting. So what we currently still do not know, we do not know what kind of combination modified techniques is suitable for this one, but this one still waiting for the further large clinical trials. And also, maybe DCB is a better choice for eruptive ones or not, we do not know. And on the platform AHS, Professor Li Yue developed a consensus on calcium nodule is still under review. So maybe, hopefully, we can give some further recommendations. This is all I want to share today. Thank you. I'd like happy to take questions.